Please don't forget to fill out the attendance records, and also please remember to fill out the program evaluations. Also, please remember to turn back in the audience response system response buttons. Today, I have the pleasure of introducing Dr. Steve Kopetsky. Dr. Kopetsky is a cardiologist and a consultant in the Division of Cardiovascular Disease at the Mayo Clinic. He's professor of medicine at the Mayo Clinic College of Medicine. He is a fellow in the American College of Physicians, American College of Cardiology, and American College of Chest Physicians. He's had scores of journal articles and textbook chapters published, and he's been the recipient of so many awards and honors, I really would not have time to touch on them all. But of particular salience, I think today he's been named the Internal Medicine Teacher of the Year at the Mayo. He's been the Cardiovascular Disease Teacher of the Year, and received the Mayo Cardiovascular Fellows Distinguished Teaching Award at Mayo, and he's been named as one of the top hospital-based teachers at the Mayo Clinic. I had the opportunity of hearing his talk at the American College of Physicians annual meeting, and I can personally attest to his abilities as a speaker and an educator. So please join me in welcoming Dr. Steve Kopetsky.
Thank you. Thank you. Well, thank you very much. It's very kind of you. It's a pleasure to come down here where people know Bohemians and they know how to pronounce Kopetsky correctly. What we'll talk about today is chronic coronary artery disease. My disclosures have been shown, but I just want to point out one here at the bottom that I'm the current American Society for Preventive Cardiology president, so I'm going to talk a lot about how to prevent things from happening. It's much better we know if we can prevent an event rather than have to treat it once it's occurred. What we'll talk about is which treatments are better for coronary disease, how often and what modalities do you follow your patients, lipid-lowering therapy. These new guidelines came out a few months ago, and then what medications should everybody be on and what lifestyle issues should they follow. So I am an interventional preventionist, and we've made a new term now, and unfortunately we don't get paid more to be interventional preventionists, but we try to go in and actually be proactive in terms of preventing events, because about 90% of heart attacks can be prevented by lifestyle, as I'll show you later on. I'll start with a case, and you have an audience response system, but a 62-year-old man comes to see you with his first ever symptoms of chest pain. He has some tightness and shortness of breath and sweating when the pain comes on. He's been there for about two to 3 months, always comes on with 2 flights of exertion, never at rest, never prolonged, goes away with rest. He works as a construction foreman, and he's fairly active, though he doesn't exercise regularly. He's a pack-a-day smoker. His father died at age 58 from a heart attack. He's not been to a doctor in over a decade, and he has no chronic medications. But he heard that aspirin was good for you if you have heart disease and chest pain, so he started aspirin. His electrocardiogram is completely normal at rest, and his chest x-ray is completely normal in terms of his heart size. So on exam, his body mass index is increased. He has a height of 178 centimeters and a weight of 101 kilograms. Heart rate 88, blood pressure a little high, 148/86. But the rest of his exam is normal, except he does have a 4th heart sound. And his fasting blood sugar is fine. His electrolytes, CBC is all fine. Kidney function normal. And his lipids are shown here. Cholesterol 144, triglycerides 85, HDL 44, and LDL 83. Really not too bad for being on no therapy. So what's the next best step at this point? Would you want to start him on a beta blocker? Would you like to give him an exercise treadmill, an exercise echocardiogram, an adenosine sestimib, or a CT angiogram? So you can go ahead and answer now. And the exercise treadmill, almost 2/3, which is a reasonable choice to do. The exercise echo, about 1/4 of you. Adenosine sesti, and no one wants to do a CT angiogram. And a few would like to start them on a beta blocker. Now, the beta blocker is a reasonable choice, but in terms of stress testing, I think it's very interesting that if you look at the evidence for stress testing, the American medical academies, the colleges, the societies have been asked to put together some don'ts for stress testing. And it's actually got together with the American Board of Internal Medicine, the family practitioners, and it's actually put in Consumer Reports in their health edition. And they call it Choosing Widely. You may have seen it. And the American College of Physicians, American College of Cardiology, nuclear cardiology, nephrologists all got in, and they put together 5 don'ts for each of their subspecialties. And cardiovascular stress and imaging made up 77% of the cardiovascular don'ts and made up almost a quarter of the total don'ts in oncology and nephrology and everything. So it was so overwhelmingly a don't. And I'll tell you what I mean by the don'ts. Imaging stress tests have advantages in the following indications or conditions. If a patient has left bundle, patient has Wolff-Parkinson-White, have a paced rhythm, or left ventricular hypertrophy with strain. Now, none of our patient had none of these, and his electrocardiogram was normal. He had no ST depression, and he's not on digoxin. So these are the ones that it really helps to do imaging, because you can't interpret the electrocardiogram when they're stressed. The other group were patients with prior coronary revascularization, which he's not had. And so the advantages, though, to doing imaging, or it does add accuracy, it localizes the ischemia, especially if they have known multivessel disease and prior angioplasty. You can measure their ejection fraction, but in this man, if you have a normal electrocardiogram and a normal chest x-ray in terms of your heart size, you have a 95% chance of having a normal ejection fraction. So really, we know his ejection fraction is probably good. And it's also very useful when you combine the imaging with the different types of stress. So this is, I'll show you some yellow heart slides. And I was talking to Stuart Christensen a minute ago that these yellow heart slides, if you want to just go to sleep or eat your food, and then when you see a yellow heart slide, pay attention, that's okay. These are ones I actually suggest you put on the wall. These next 2 slides are on the wall in our ER at St. Mary's, which is about 100,000 visits a year now, that on how to pick a stress test. And so you look for the things we just talked about. If none of those are present and they're able to exercise, then just do a treadmill without any imaging. But if they have some changes in their electrocardiogram and they can't exercise, then do a pharmacologic stress test, either adenosine, SESTI, or dobutamine echo, whatever you have available. But if they can exercise, always exercise them. It gives you so much more information. And then when to pick a pharmacologic stress test, you almost pick it by what you shouldn't do rather than what you should do. Meaning, for instance, if you have a patient with asthma, then don't do adenosine or dipyridamole stress, because that can exacerbate the asthma. Dobutamine's okay. If you have a patient with a heart block, high-grade heart block, adenosine can make that worse, dipyridamole too. Or poorly controlled hypertension, the dobutamine can raise their blood pressure. Or a patient that has glaucoma. Now, glaucoma is not really a contraindication for dobutamine, but atropine is. And sometimes we have to give atropine to raise the heart rate up. And so you can't give atropine with glaucoma. And then patients that have high-dose beta blockers, sometimes you just can't get their heart rate high enough. So you use some other stress agents. We should always withhold caffeine. Every research study basically that's been done of these agents, adenosine and dipyridamole, has held caffeine. Of course, we never do that. And the other thing to point out is we're seeing now a lot of CT angiograms for PE or dissection acutely in acute coronary syndromes. And if someone's going to do that, then we ask them to also do a CT for coronary disease, because it really doesn't add any dye. In fact, it may be even less radiation, because it's usually a different, faster scanner machine. And so do that instead of doing the PE dissection rule out, then sending them to us for a treadmill. So this patient got just a regular treadmill, and we use the Duke score. I don't know, do you use the Duke score here much, or not often? It's nice in the ER where it standardizes how we do things, and it's a pretty simple thing to use. It's a score, comes from the time on the Bruce protocol, so in minutes. Use the angina index, which is if you have no angina, it's 0, non-limiting angina 1, and limiting angina is 2 points. And then you measure the ST deviation. And so the score equals the number of minutes, minus 4 times the angina score, minus 5 times the ST score. And this man, for instance, went 6 minutes, and he stopped because of angina, and he had 2 millimeters ST segment depression. So he went 6 minus 4 times 2, minus 5 times 2 is a minus 12. And the way to look at this is if it's higher, like more than minus 12, minus 10, which would be minus 12, it's even lower, then that's a high risk. Annual mortality of about 5%. A low risk is a plus 5, and then intermediate, it's in between. So this guy was a pretty high risk patient. So what to do next with this higher risk patient? For those of you that didn't start him on metoprolol, would you like to start him on some beta blocker? Would you like to start him on amlodipine and sublingual nitro? Start some atorvastatin? Do a coronary angiogram or a CT angiogram? And a coronary angiogram, about 60%. And those of you that didn't start him on metoprolol would like to start him on something. And I think it's very reasonable. That's what we actually did on him. And you can say, oh, wait a minute, why did you do an angiogram? Well, he had pretty significant test. He was 62. His dad, remember, had a heart attack at 58. He was very concerned about that. And plus, if you have a large amount of ischemia, over 10% of your myocardium, we still don't know what's the best way to handle them. And so a lot of times we'll just do an angiogram on them. So he had a 90% LAD, a 30% right, and a 50% circumflex vessel stenosis. So how and when do we choose medical therapy, in chronic CAD patients? How should we handle this fellow? And the COURAGE study has really given us about all the information we've now know, and I can show you a single slide here in a minute that basically has 20 years of research summarized in how we should treat patients. And for those of you that may not be aware of the COURAGE study, it was percutaneous coronary intervention and optimal medical therapy, and I'll show you what that is, versus just optimal medical therapy alone. And most of us, including me, thought when we started this study, this is kind of silly. I mean, geez, everybody knows that angioplasty is going to add something over and above doing just optimal medical therapy. And it was patients that were pretty sick. They had stable disease, but they could have been class 1 through 3, which means 3 is walking less than 2 blocks or less than a flight of stairs. They could have been stabilized class 4 angina, which means symptoms at rest. And they all had to have a stenosis of at least 70% in one proximal artery and have objective evidence of myocardial ischemia, like our patient. Or if they didn't have provocative testing, then they had to have at least an 80% narrowing in an artery. So these were pretty significantly stenotic patients. Their arteries were quite stenotic. We didn't enroll class 4 anginas, didn't enroll patients that had stress tests positive in the first 3 minutes, because that could be left main. Didn't have refractory heart failure. They had to have an ejection fraction over 30% and not prior revascularization in the last 6 months. So they were randomized, and it's very interesting. They got the PCI or medical therapy versus medical therapy alone, and everybody got aspirin. Everybody got clopidogrel if they were aspirin intolerant, and if they got a PCI, they got clopidogrel instead. And it's interesting. I think what really made the study successful was the nurse managed the follow-up. The nurses saw them every 3 months, called them, said, are you taking your medicines? Are you being active? Are you eating right? Are you taking care of your diabetes, et cetera? And they asked and did things that a lot of physicians just don't have time to do, to be honest with you. And even after the study's over, we have a COURAGE nurse now that does this and takes care of the patients chronically. So this was the treatment, and it's basically on one slide. Metoprolol, sustained release, amlodipine, isosorbide mononitrate. If they still had pain, they got isosorbide. And then if they had hypertension or LV dysfunction, they got lisinopril or losartan if they had a cough. And all these medicines, as you notice, are generic. They started out getting simvastatin alone or with ezetimibe with a goal of a 60 to 85. And later, all the statins were added into the study because the drug companies realized that this study was going on and on and on for years, and they didn't stop it early, saying, gee, the angioplasty arm is doing better. So all the drug companies wanted to be involved with it. And then after the LDL was to target, they tried to raise HDL with exercise, niacin, sustained release, and then fibrates. And I have crossed out niacin sustained release because in 2 subsequent studies, the AIM-HIGH study, which was a niacin trial, and the HPS Thrive study, which was a niacin trial, both of those raised HDL 4 or 5 points. Neither of them lowered event rates, but both of them increased intracranial bleeds or events. And so we know if you're on a statin, adding niacin doesn't add any benefit, and it could cause some harm. So I take patients off the niacin when they're on a statin. And then fibrates have never been shown to reduce mortality, so those are kind of fallen out of favor too. And here's the outcomes, and you can see that the outcomes, the angina-free state was about the same in each group, although I must admit that it took a little longer to get angina-free in the patients that were on medical therapy. It took like 6 to 9 months. And then the optimal medical therapy, I want to point something out. It's not just adding medicines to patients carte blanche and not paying attention to them. And that's shown here by an old study of only 19 patients. And they were all on propranolol, which was the first beta blocker approved in this country. And they either got placebo added to it, isosorbide dinitrate, nifedipine, or both isosorbide and nifedipine. And they did stress tests on them. And they found that if they got nothing, they could go about almost 8 minutes. If they got just isosorbide or nifedipine, they did better. But if they got both of them together just indiscriminately, they actually didn't do as well. And probably about half of the patients did worse on all 3 of these drugs, so a nitrate, a calcium blocker, and a beta blocker. And if you look at why, it's because their rate pressure product was down. It dropped. And that was when they started to have the symptoms. And if you look at why it dropped, it's because their peak systolic blood pressure dropped. So be careful just giving medicines indiscriminately, especially to elderly patients, because they'll drop their pressure and they can't do as well. So the COURAGE outcomes are shown here, and you can see there really is no difference in the major events: death, non-fatal MI, stroke. There was a difference in revascularization, but not in major events like death or MI. And none of the subgroups were any different, meaning men, women, old, young, diabetics, smokers, etc. And so the conclusion was that as the initial therapy in stable coronary disease, that PCI did not add anything over and above optimal medical therapy in terms of risk of dying or having a heart attack or a major event. Now, some people have interpreted that is that medical therapy is superior for all patients, and that's not true. It is not superior for all patients. But optimizing medical therapy and lifestyle therapy, remember we talked about the nurses following them, is appropriate as an initial management in these patients. And if they do well, they have good control of their symptoms, that's fine. If they develop more symptoms, become unstable, then obviously they need to go be considered for angioplasty or other types of revascularization. Now, we've looked at arterial beds being narrowed in 3 different areas now as initial therapy. One is the heart, I just talked about. That was the COURAGE study, and stents equaled medical therapy. We've looked at kidneys. As you know, the renal, it really isn't any better just to go in and as initial therapy, dilate a renal artery. And even in the brain, actually, medical therapy has been shown to be a little better because than the stenting. That was the Sampras study, which is being repeated now with a little better techniques. But actually, there was thromboemboli, and small thromboemboli in the brain can cause troubles. So really, nowhere has initial medical therapy shown to be the best initial option. Now, why is that? Why do we do so many angiograms in this country? If you look at the patients and the cardiologist's perception of the benefits of stenting, here the blue is the referring doctor, the white is the interventional doctor, and the yellow is the patient. You can see that all 3 of them thinks that the intervention, a stent, will reduce angina. But the referring and the performing angioplaster knows it doesn't really reduce their MI rate much or their death rate much. But the patient has a different perception, don't they? Patients think it really works, and patients keep coming back until they get it. Now, when I order a cath at Mayo, an angiogram, the computer that I order it through asks me questions. How many antianginals is this patient on? 1, 2, or 3? Have you done a stress test? Yes or no? Is the patient high, intermediate, or low risk? And I envision in my lifetime that one day that computer is going to say, you didn't give enough medicines, or you didn't get a stress test yet. It won't even go to a human. It'll just be the computer telling me what to do. But you may have seen some of the articles by Atul Gawande, very interesting articles in New Yorker a few years ago, talking about the angiogram rate and the angioplasty rate in the United States. And the darker it is, the higher the angiogram rate. I want to point out, I'm from Texas, so I can point out that in South Texas and Harlingen, where many of our patients go, has one of the highest angiogram rates in the country. But the same socioeconomic group out in El Paso County in West Texas they're the same risk factors, but they have a much lower rate. And it turns out that Atul Gawande says anyway that the doctors in Harlingen own the hospital that does the angiograms. And I have had patients that go to Harlingen. And I saw a guy the other day, and I said, we need to do an angiogram on you. He was up in Rochester. And I said, I'll tell you what the risks are. He says, I know the risks. I've been to the film. I said, what do you mean you went to the film? He said, well, down in Harlingen, they show the film, the pre-cath film at the mobile home park where we all live, and they give free coffee and free popcorn. He says, we all know we're going to get a cath anyway sometime, so we go watch it, and we know all about it. Now, how about bypass versus angioplasty? When do you do that? Well, the Berry trial showed us that survival without diabetes was really the same in the two groups. And the benefit was seen in the diabetics who got a bypass if they got an internal mammary artery. And that still pretty much drives our practice. If they're diabetics, we tend to cath them earlier and revascularize them with bypass earlier than if they're not diabetics. And there's guidelines out now that you can update every year or two. You can get them off the internet of when to do a bypass, when to do PCI. Obviously, red is not recommended in left main or left main with additional coronary disease. Our patient was basically a two-vessel disease, not diabetic, and so he could have gotten either. And the ischemia study, which is an $80 million trial now the NIH is funding, is like COURAGE, but it's a step earlier, meaning you don't need an angiogram. So you get the stress test, and then you get randomized. And if you get randomized to medical treatment, they do a CT scan to make sure you don't have left main disease. And if you don't, then you go ahead and get medical treatment. And the other arm would be, again, the PCI. And that'll be out probably in 4 or 5 years. So what to recommend for our gentleman? Well, we placed a drug-eluting stent successfully. He did well with that. Now, how do we follow him? How do you follow him over time? I'd like to ask you, should we just follow him by treating his risk factors and follow his symptoms? Should we do an annual treadmill? Should we do an annual exercise echo, an annual adenosine CESTI, or an annual dobutamine echo? And treat the risk factors, 73%, or about a quarter say do an annual treadmill, 5% an annual exercise echo. I would certainly agree with treating the risk factors and following the symptoms. And if you look at the evidence that an exercise test alone is really poorly diagnostic post-revascularization. So if you're going to do a stress test, do a stress nuclear or stress echo, something with imaging. But restenosis rates have dropped significantly with drug-eluting stents. And as the restenosis rates have dropped from about 30% with the old balloons and the non-drug-eluting stents now to about 10%, doing a stress test will give you a false positive rate. They used to be 37%. It's gone up to 77% now. So if we're doing just routine stress tests with imaging on all these patients, we're going to get a lot of more procedures that are done, repeat angiograms, et cetera. And that hasn't been shown to reduce cardiovascular events or cardiovascular mortality. And there's really insufficient data to justify one particular frequency of testing. And so the guidelines say perform stress testing only when clinical scenario dictates. So if the patient comes back in and says, gee, I've got more pain, I have similar symptoms, I get shorter breath, I have heart failure, something like that, then certainly it's worthwhile doing. But just as a routine, it is not recommended. Now, the lipid guidelines, they came out, I want to talk about lipids for a little while. They came out about the 11th of November. And the New York Times, picks up on things very quickly. And I don't know if anybody saw these cartoons in the New York Times, but this very clever guy, Brian McFadden, came out with this cartoon within a week. And his take, of course, was like the rest of the country. These are all guidelines written by the drug companies, and they're trying to get everybody on statins, which, of course, they weren't. And he said, check your pulse. If you have one, you should be taking statin drugs. But how will the guidelines affect us? Guidelines are really kind of like, sometimes they're like remodeling your house, or your office. Sometimes you'll put a new coat of paint. Sometimes you'll add a bathroom, maybe a new refrigerator, a deck out the back. Well, these guidelines, it was like tearing the whole guideline down and restarting all over, because they did away with the LDL goal, which is what we all talk about when we go to a cocktail party. and see our patients, and they say, "Oh, doctor, guess what my LDL is?" But the reason was they had a new recommendations on how to look at the evidence. And you're not intended to read all the fine print here. But suffice it to say that they said we're only going to take certain studies that meet certain parameters. So you couldn't have like a dropout rate more than 20%. So that's why the SHARP study, for instance, in nephrology, they gave statins to renal insufficiency patients. That wasn't used because they had a 22% dropout rate in SHARP. But they said, we're only going to give you certain papers to read, and that's all you can use to make your decisions. So what they've done is they've said, well, let's look at these papers. So what were the papers that they looked at, and what was the end point of those statin studies? If you look at the study, the treatment, and the control arm, this is about 80,000 patients, and this is household names of studies, like 4S and CARE and ASCOT, ALLHAT. Lots of patients you can see. The treatment arm was usually a dose. In fact, it was always a dose. It was never to say get the LDL to 70 or get it to 100. It was always just give a dose. And guess what the control arm was? Either placebo or lower dose, basically. So no one's ever done a study where they say, okay, we're getting an LDL to 70, except for the COURAGE study I showed you a minute ago, where they said get the LDL to 80. But that wasn't a statin study. That was an intervention versus medical therapy study. So they said, we've never had a study that looks at a certain dose, getting it to a certain level. All we've had is dose studies, so we're going to go with dose. And so they said, we're not going to continue to treat to LDL target. Now, what's the problem? Well, the current randomized trial data doesn't tell us what the target should be. It doesn't really say. They never had a target. And certainly they never compared one target to another. Is 70 better than 80? Is 80 better than 100? We don't know. There's unknown rate of additional adverse effects. As we raise statin doses, there's more side effects, as we're aware. And then, so the unknown net benefit from a treat to target approach, with the target being an LDL. So they've said, okay, we're just treating it, we're just giving a dose. It's going to be like aspirin now. You give the dose, don't worry about it. Give them 81 milligrams, let them go, that's fine. But the guidelines are interesting. There were 4 groups that should benefit, that have been pointed out. One is those with clinical atherosclerotic cardiovascular disease, like our patient, the 62-year-old man. One is patients with an LDL over 190, or if you're thinking in Canadian terms, it's a 4.9 millimoles per liter. Diabetics, age 40 to 75, with the LDL in this range of 70 to 189, or a 10-year risk, and I'll show you how to calculate risk, over 7.5%, again with an LDL in the 70 to 189 range. And it should be for patients only age 21 or older that are statin candidates, meaning not severe dementia, who can't take their meds, et cetera. And it's not for heart failure patients. And let me just point out that the reason is not that it doesn't work in heart failure patients, but almost all the statin studies have excluded heart failure patients from the study. So we just don't have the data, but we all believe it works. Unlike dialysis patients, where really, if you give dialysis patients a statin, it really doesn't lower their event rates much. Their event rates are very high. Does that mean we don't do it? No, we still give them statins, but the guidelines just don't apply to it. Now, this is another yellow heart slide, and this kind of summarizes it in one page. So you measure your patient's LDL. If they have disease, then it's a high-dose statin, and I'll talk in a moment about what these doses are and give you an easy way to remember it. If they have diabetes type 1 or 2, age 40 to 75, LDL in this range, 70 to 189, then do their 10-year risk. If it's less than 7.5%, that's a moderate dose. If it's over 7.5%, it's a high dose. And again, we'll talk about doses. Now, does this mean, what if a patient's 39? Do you ignore them? Of course not. What if they're 76 years old? Do you ignore them? Of course not. And the way I would approach the older patient, and I'll show you how to approach the younger in a minute, but the way I'd approach the older patient is if a patient comes in there 80, I tell the fellows and the residents, ask one question of yourself. If this 80-year-old man had a heart attack today, would you take him to the cath lab? If the answer is yes, then by God, spend 30 cents a day to try to prevent the heart attack. Don't say, well, he's over 75 or I'm not going to give him statins anymore, or try to lower his cholesterol. The third group is not diabetics, again with that same age and same LDL. Do a 10-year risk, and if it's over 7.5%, then a statin. And then LDL over 190, that's a high-dose statin. So this basically is the whole guideline in a single page. And the next thing to remember is that when you treat LDL, it doesn't matter how you lower it. With the statin, they're all the same if you achieve the same LDL goal. This idea about pleiotropic effects really doesn't bear out in terms of the different statins having different outcomes. So the doses are shown here. It's high, moderate, or low intensity statin therapy. And the high will lower LDL at least 50%. The low lowers it less than 30%, and then everybody else is in the middle. Now, the way that I remember this is I remember three things. The high is atorvastatin, 40 to 80, or rosuvastatin, 20 to 40. Now, what are all these different things? Well, the yellow means it was either in a randomized trial or it was in the cholesterol treatment trialists meta-analysis they put in Lancet a few years ago of 170,000 patients. If it's in white, that means it's assumed benefit. They haven't ever studied rosuvastatin, for instance, of 40, but we assume it works because 20 works. If it has an asterisk, asterisk means that it's unable to tolerate the 80 milligram dose. You got to take the 40. And then here are the abbreviations, as you can see. And so remember atorva, 40 to 80 is the high. In the moderate, I remember atorva, 10 to 20. Now, both of those are generic, and that's very nice. And the low, I remember Simva, 10 milligrams. So remember, two drugs, three different doses, and you've got basically all three arms. Now, this gets confusing, doesn't it? And so, we have European guidelines, we have U.S. guidelines, we have Canadian guidelines. Well, we all read the same papers. We've all been involved with the same drugs, the same types of patients, and they have guidelines. What do their guidelines say? Well, in the last few years, we came out with ours that said statin dose only is the goal. But Canadians and Europeans said, hey, you can do both, which I think is pretty reasonable. I think that's where we're going to migrate to eventually, is let's do both. You can pick your choice. But we're certainly not there yet. Now, the last thing to do is to risk stratify these patients. And there I recommend clinicalc.com. There's an ACC-AHA webpage you can go to, but it's a little harder to navigate. And my definition for easy navigation is I can pull this up with a patient next to me, have it up, and talking to them about it within 15 seconds. The ACC takes me 2 or 3 minutes. Don't get the app because you got to pay for the app. Just use the web page. When you bring up clinicalc.com, you'll see this page. Go to pooled cohort, click on that, and here's our patient. You can put in the data, 62-year-old man, cholesterol, blood pressure, smoking, diabetes, HDL. Now, what's not here? LDL. Has LDL ever been involved in any risk stratification? No, never. Why do we fixate on LDL if we don't use it to risk stratify? Well, there are different reasons, but we calculate LDL or calculate HDL and then or measure HDL and then calculate out LDL. But regardless, none of them have the LDL in it. So you click on it, and it'll tell you that this man's risk was 16% for cardiovascular disease in the next 10 years. And with optimal risk factors, it goes down to 7% or 6.9%. And it shows here in a graphic style. And you can say, well, what is optimal risk factors? And you click right here on this question mark, and it says this is optimal. Cholesterol less than 170, HDL of over 50, systolic pressure of 110, don't take medications for hypertension, don't smoke, and not be a diabetic. And so that it's all right there, and it'll tell you what dose to give and what dose range they're in. And one thing I think is helpful, though, and you can only do this for patients less than age 60, so I put in a 59-year-old man here, is to put in the risk factors, the same if you make this guy now 59, the risk factors are 13 versus 5% optimal. But sometimes that's not enough to get people to change. So then you look at the bottom, and it'll give you the lifetime risk. So this man's risk over lifetime is 50% for a cardiac event. And when I say cardiac event, cardiovascular event, that's heart attack, fatal heart attack, or stroke. That's the three things this measures. And then if they do optimal, their risk goes down to 5%. It's really incredible, isn't it? How much we can reduce our risk for heart attack, fatal heart attack, and stroke with just some simple things early in life. So who else to consider for statins? Well, there's other risk factors like LDL over 160, family history. It never includes the brother that had a heart attack last week who's 2 years younger than your patient. I mean, that's an important, family history tidbit. If they have a high CRP, if they have high coronary calcium, over 300 Agustin units or 75 percentile for age and sex, it's been shown to be helpful to give them a statin, even if asymptomatic. And then ankle brachial index. And the thing about that is ankle brachial index is rarely low. I mean, once you see it's low, it's pretty late in the disease usually. And then if they have a high lifetime risk, like that 50% man I just showed you. And so these additional risk factors, they pointed out in the guidelines, there are some that are recommended on every patient, like family history, CRP if appropriate, core cal if appropriate, ankle brachial index. They don't really have a plus or a minus for the other testing, like chronic kidney disease, although you can get that easily with a creatinine and an estimated GFR. The one they say don't do regularly is the carotid medial thickness, because it really doesn't add much. When you do that, you get some info from the carotid plaque, that helps you, but just doing the carotid medial thickness does not seem to help. And then this is the first guideline really to ever talk about what to do when you initiate therapy. And they actually point out, talk about adverse effects. No guidelines ever really talked about statin intolerance, but it clearly exists. It's probably at least 10% of the patients, maybe 20. Yeah, there's about 35 million patients now who are either on statin or the statin's indicated for them. These new guidelines will probably raise that up to about 43, 45 million patients, which is maybe a quarter of the adults in the country. And so we're going to see a lot of statin intolerance and drug-drug interactions. And then talk to the patient about their preferences. Show them how much it can benefit them in absolute terms. Don't just say it lowers your risk by a third, because if it's a young woman whose risk is only 0.5% over 10 years, then that doesn't mean much. Tell her in actual numbers, number needed to treat. And then, of course, reemphasize healthy lifestyle, which is extremely important. Two groups I would recommend you always checking CKs in, and one is the African American man. If you do baseline CKs in an African American man, about 8% of them are going to have a high CK over 3 times normal. That's really incredible. So with this high rate of high CKs over 3 times normal, I would always check a baseline CK in these patients. You don't have to do it in everybody else. It's pretty low, but I would in those. The other group to be aware of is the Asians, and especially the Eastern Asians, the Chinese Asians, the Japanese Asians. This has been shown that any myopathy is much more common in an Asian. If you look at the HPS Thrive study, you can see that myopathies in the Chinese Asians versus the Europeans was about 10 times higher in that group. And if you look at equivalent statin doses, Asians achieve a much greater LDL reduction with the same dose. So the recommendations are, and this isn't in the guidelines, but this is just supported by science, consider starting a lower dose, like a quarter of a dose. So instead of atorvastatin 20, start atorvastatin 5, and then go up if you need to, because they have a lot more response. They're going to have a higher incidence of side effects. For those patients that say, I don't want a statin, which is about half of my practice now, I encourage them to try other things that will lower their LDL, like sterols, fibers, soy protein, nuts, barley, whole grains, things like that. If you want to send me an email, I'll give it to you at the end of the slides, and I'll send you a little pamphlet we give patients. And they can try that for 9, 12 months, and then if that doesn't work, then come back and we'll try something different, like a statin. But I wouldn't do this if they've got disease. I would really encourage starting them on a statin if they have coronary disease like our man. And finally, don't forget hypertension. Why do I say that? What's the single most neglected area of medicine? I really am convinced it may be hypertension. I don't know what you think. But if you look at, and you know these numbers, but 1/3 of adults have hypertension. About 36 million have uncontrolled hypertension. And 40% of the uncontrolleds are unaware they have hypertension, which is kind of sad. And at least 16 million in the U.S. are on meds, but not yet under control. So we're giving people some meds, or we're not giving them meds, but neither way are they getting controlled. But the single most compelling statistic that's really an eye-opener for me is that nearly 3 out of 4 people with uncontrolled hypertension, so we're talking about, millions, tens of millions, 26 million patients, visited a healthcare professional at least twice in the last year, and they're still uncontrolled. That doesn't make sense to me. You would think if they're going to the doctor, we could do a better job of controlling them, but we're just not. So the future is about prevention. And prevention is about 2 things. It's adherence to therapy and it's behavior modification, neither of which I learned about in medical school. But I do want to point something out, just to finish up with adherence to therapy. If drugs are free, do we take them? Are we adherent to drugs? And this was the MI-FREE study, which you may have heard of. It was 6,000 patients. They all had a heart attack, and they were given, followed for 3 years, and they were either given full free medicines or usual coverage. And these were the medicines, ACEs or ARBs, beta blockers or statins. And even if they had to pay for them, that isn't much. It's maybe $50, $60 a month with the copay. But they said, let's call them adherent if they take at least 80% of their pills. Now, I work at a big clinic, and I've asked my chair of cardiology, can I show up 80% of the days I'm supposed to work, and would you call me fully adherent? He said, I'd call you some other things, but I sure wouldn't call you fully adherent. But you can see, it doesn't matter what the drug is. If it's free, they take it about 25, 30% of the time. If it's not, it's a little less. But even if it's free, look how many take all 3 of these drugs in their heart attack patients at 3 years. So even when medicines are free after a heart attack, only 12% of patients take all of them. So I just want to leave you with these thoughts, because I always thought when I give a patient a medicine, they take it. They say, oh, doctor, I will take every pill you tell me to take. I believe you. You're the greatest doctor in the world, and I will do what you say. That doesn't happen. But so I've tried to impart to you how to take care of these patients, but I really think the future is going to be behavior modification and adherence to therapy, because we're not doing a very good job at either. So thank you for your attention. I appreciate it. Do we have a few minutes for any questions, or so I got 12:55, or do we need to go, or is it?
Thank you very much for an excellent presentation. I wonder if you could spend just a minute talking about PET stress tests, and do they fit in your algorithm for evaluation of chest pain?
Yeah, PET stress tests, we reserve those for the people that we talked about. They need imaging of some sort for those criteria I talked about, and then we do it in primarily if we can't get images with an echo or good images with sestamibi, and that means usually a woman over 100 kilograms because of breasts we can't see well, or a man over 120 kilograms, and that's who we generally do PET stress testing on. If we want to look at viability, it can also be helpful, but we can tell viability fairly well from in the smaller patients from the echoes and the nuclears. But PET can have some advantages in viability. Yes, sir.
Which patients are appropriate for the calcium scoring CTs? I saw that on one of your slides, and I was just wondering which are the patients you would recommend get that.
Yeah, that's a good question. Who should get a calcium scoring CT? It usually is better in the middle patients. The patients that have LDLs of 190 or 200 or have disease, you don't need to do anything. If they're younger patients, very low risk factors, it usually doesn't help you much either. It's the intermediates, the one where their LDL may be in a range, like 140, 150. Their blood sugar is a little high. They're a little overweight. Their older brother had a heart attack. 5 or 6 years older than them. And if you think it would, especially if you think it would help them change. Now, some studies have shown that CT scans will help people change. Most of them have shown it hasn't. You can show a patient their calcium in their coronaries, and they say, it doesn't really bother them. But I do think that group of patients is helpful. I can tell you that if you do a CT scan and it's positive for calcium, I don't really see a reason to redo them because it's there. If you do a CT scan and it's negative, then the recommendation is wait maybe 3 to 5 years before you do it again. Don't just do it every year, but I'd wait a few years.
In the ClinCalc, I'm sorry, Steve. No, go ahead. In the ClinCalc website, which is great, your website gives you a 30-year risk. Mayo Clinic's website, it's cool, but it doesn't fit with the new guidelines. Just throwing that out there. But in the calculator you got, it says smoking, not smoking. You know, all of my patients quit like on their way into the clinic that day. Are they smoking? You know, how much smoking do you use? And then I heard you mention EKGs in the ER. Is that what you're doing at St. Mary's? And your thoughts on that?
Yeah. The smoking thing, it's interesting. If we call now smoking 100 cigarettes in your lifetime. So that's, and most of us are saying now, if you have to quit for a year for you to be called an ex-smoker. The other thing that's interesting is, you know, in Rochester, we outlawed smoking, you know, everywhere. You can smoke in your house and things like that. But it was very interesting. This has been shown in other populations. When we stopped, everybody couldn't smoke in public or in the restaurants and all. The smokers, their heart attack rate went down by about 25%, almost overnight. The non-smokers' heart attack rate went down 35%. So just you and me being exposed to smoke, or, you know, a spouse that smokes. So it really is, it affects people quite a bit. So I would be very stringent with the smoking. The other you asked about was the EKGs in the ER? Stress tests in the ER. Oh, stress tests, yeah. We're, you know, 80% of the time now we have a chest pain unit in the ER. 80% of the time we're doing standard treadmills because 80% of the time you don't need imaging. And the treadmill allows us to be a little more flexible in terms of timing and not having to have so many other people involved. But we have good results. And remember, on the stress test, the single most important piece of information is not did they have pain, it's not did the ST segments drop, it's not what did the echo show, but it's how far they went. It's pure and simple how far they go. And if they go over 5 or 6 minutes, that's a very good sign over the next, you know, unless they get profoundly ischemic in that 5 or 6 minutes.
Do you have any recommendations regarding fish oil?
Fish oil, you know, have you read Jerry Diamond's books, you know, the Guns, Germs, and Steel, things like that? He points out that there was this, every continent seems to have a population 150, 200,000 years ago that had a population in the middle of the continent. There was a famine, and they all went to the sea for more, you know, to live on the seacoast to get more food, and all of their brains increased by about 25% in size over a few thousand years. You know, 25% of a baby's brain is omega-3 fatty acids, DHA and EPA, and ours is a little less, but we have a lot of fish oil. So if you look at the fish oil data for primary prevention, it really doesn't show much benefit. If you look for secondary prevention, it really does show benefit. You know, the Gysi Preventione study, these others, taking 1,000 of EPA and DHA per day. But when the JAMA article, Internal Medicine, came out, you know, last year and a half or 2 years ago, they put primary and secondary prevention together, and all the primary prevention studies diluted the secondary prevention benefit, and they said fish oil doesn't help. But there's one graph in that article that shows up till about 2005, 2008, it showed benefit, and then it dropped off because that's when all the primary prevention studies came out. So I tell patients, if you want to take it for your heart, I'm not sure it's going to help you for primary prevention, but secondary I think it will. But it does so many other good things, like for your brain, you know, for memory. It helps the dermatologist, Stuart, ask your wife that there's some good articles in Derm that shows you have less wrinkles if you take fish oil because it lengthens your telomeres, which are the caps on the ends of the chromosomes, that when the telomeres get too short, the chromosome can't divide anymore and the cell dies. So if that is in the skin, your cell lives longer. Now, once I told my wife that, I have to buy twice as much fish oil because we take it every day. So I'm actually a fan of fish oil. Okay, well, thank you for your attendance. I appreciate it.